We will now draw the passport for the Peanut Gallery Draw Prize.
I shook it up really well.
And the winner is Peter Engbrecht. Congratulations, Peter. A question has come up about handouts of today's presentations. We have some handouts and other presenters did not have handouts, but anybody wishing to have one, I would suggest that you please give our Winnipeg office a call and ask for Ellen Carr, and she'd be happy to make arrangements for you to get a handout of today's presentations. The closing topic this afternoon is the impact of rehabilitation on quality of life by Dr. Tania Bruno. Dr. Tania Bruno is a duly certified specialist in physical medicine and rehabilitation with special expertise in electrodiagnosis and multiple sclerosis rehabilitation. She completed her undergraduate medical degree at Queen's University, where she was awarded the Henry Kaufman Prize for Empathy. She completed her residency training at Dalhousie University, was awarded a Killam Scholarship, and then went on to complete a clinical neuromuscular neurology fellowship at the Montreal Neurological Institute. She was appointed staff and assistant professor in the departments of medicine and neurology and neurosurgery at McGill University, and was embedded in the Montreal Neurological Institute's large MS clinic for several years, even once transitioning to a role as MS psychiatrist and director of EMG at Toronto Rehab, a part of the University Health Network. Dr. Bruno is now a lecturer and clinician teacher in the Department of Medicine at the University of Toronto and is a strong champion of the holistic approach to MS rehabilitation. At Toronto Rehab, she manages a large MS outpatient practice and leads a dedicated rehabilitation team. She is particularly engaged in collaborating on MS exercise endeavors and MS advocacy. Amongst her various accomplishments, she feels especially privileged to have been part of an expert panel of reviewers for the National Guidelines for Exercise in MS, as well as the MS Get Fit Toolkit. Please welcome to the podium Dr. Tania Bruno.
Thank you very much for having me, and I hope my voice doesn't give out. I have some water tucked away under here, and you may see me take a few sips now and then. I'm very happy to be invited today to talk to you about this topic. And some of what I'm going to talk about today, I think, may be partly familiar, and to some of you, it may not be familiar at all. And that I want definitely to change. These are my disclosures. That's a front shot of where I work at the Rumsey Center, which is part of the University Health Network, Toronto Rehab. I am a physiatrist, otherwise known as a specialist in physical medicine and rehabilitation, and I'll talk more on that subject in a little while. Though I have these disclosures, I really don't feel a conflict of interest in talking to you today about what I will be talking to you. I'm hopeful that by the end of this talk, you'll all be able to describe the main purposes of MS rehabilitation, and I want you to be able to distinguish the different scope of practice between the MS physiatrist and the MS neurologist. And I want you to identify ways in which rehabilitation can address some of the symptoms and try to improve function in persons living with MS. So we're going to go through an MS refresher, and I'm going to go through some very key core rehabilitation concepts with you. I want you then to meet the team, because rehabilitation is really team-based. And I'm going to say right off the bat that the team that I'm going to present may not be all inclusive. In fact, I don't think I have a neurologist on the list, and my husband took objection to that because he's like, where's the neurologist? But no, definitely the neurologist is part of the team. We're going to go through a symptom survey and an approach to management. And we're going to talk about optimizing function across the spectrum of disease burden. And then I'm going to make some concluding remarks. If there is time, because I know I do have a tendency to drone on and on, if there is time, we will go through a case study of a person who has benefited from MS rehabilitation. So, as you know, MS is deemed a chronic inflammatory immune-mediated disease. It affects the central nervous system, so brain and spinal cord, and it's been really hotly debated in two camps. Is it fully autoimmune, or is it degenerative and then autoimmune? How much of a contribution is from each particular causative agent? Really what you need to know is that it attacks myelin, and it attacks the cells that make myelin, the oligodendrocytes, but it also attacks the underlying neurons. And it attacks those axons, the parts that connect one nerve cell to another nerve cell to communicate via electrical and chemical signals. So all in all, the take-home point from this slide is that it attacks everything in the brain and the spinal cord. And so you want a multi-pronged approach to try to maintain the function and maintain capacity. Rehabilitation is one way to add to the armamentarium. So, as I said, everything can get attacked, but there are some areas that are predisposed, and those are the areas that are involve tracts of densely myelinated axons. They tend to surround deep venous structures, and things that can be very hard hit would be the optic nerve. Many of you may have experienced optic neuritis in the past. The periventricular white matter, so the white matter deep inside the brain. The brain stem, which is very important in regulating all of our baseline important functions, like maintain our respiration without having to think about it. The cerebellum, important for coordination, movement planning, and even emotion control, and in some facets of cognition. And then the spinal cord, which takes all that information from the brain and disseminates it out to the other organs in the body. MS, as probably each one of you knows, is a diagnosis of exclusion. That means that there are other things that could produce MS-type scenarios. And having expert care and making sure all other possible competing diagnoses have been ruled out is very important. And this is why there are MS centers that specialize in this, because it's not always easy to know. But, you know, with a convincing history and with our MRI technology these days, it can be made relatively confidently when it's given as a diagnosis. There are additional workups that can be used. Sometimes they will analyze the cerebrospinal fluid with a lumbar spinal tap. Sometimes blood work is necessary, and I've had many a patient come to me and say, you know, I think I have Lyme disease, and I really, really want to get tested for that. Can you help me with that? There are other immune-mediated problems like central nervous system lupus. There are predispositions to getting repeated strokes. There are other infectious agents that can cause problems that can mimic. But usually these mimickers are ruled out. Evoked potentials aren't that important anymore. We'll skip over them. EEG to look for seizure activity, EMG to rule out things in the periphery, so in the nerve roots, the nerves in the arms and legs, and the nerve endings, the space between nerve and muscle. You know, sometimes that is relevant in trying to figure out if a person has MS or not. And then, of course, genetic testing. There is no specific genetic test for MS at this time, though we know that there are multiple genes implicated in making a person vulnerable to getting MS. The causes of MS are very complex, and likely this involves multiple factors and potentially a different combination of factors in each particular person. So obviously there are persons of certain ethnic backgrounds that are more at risk than others. Northern European, Caucasian are the most vulnerable. Environmental exposures, most notably infections acquired at a very vulnerable age, typically sometime in adolescence, especially Epstein-Barr virus, which is known to create infectious mononucleosis. These have been implicated. Other toxic exposures, smoking, for example, lifestyle choices, obesity in adolescence has been shown increasingly to be important. And altered exposure to sunlight or altered vitamin D immunologic pathways. And that has become very well established, and I think probably most of you in this room are supplementing with vitamin D at this time. MS is one of the leading causes of non-traumatic disability in young persons aged 20 through 50. So it really hits hard at the most productive years. And this is very important from a rehabilitation purpose because we're trying to address the effects on the whole person. And there are going to be effects across a person's spectrum of roles and opportunities. The age of first diagnosis varies dramatically. It can be childhood, and I follow persons who have childhood cases. And then there can be diagnosis after the age of 50, and I think the oldest patient I've ever had diagnosed with confirmed MS was 82. So really it spans the whole spectrum, but really most patients are going to be in their younger years when they get the diagnosis. Females tend to be more commonly affected than males, and up to 5% of MS sufferers can identify a first-degree relative with MS. So that's usually siblings, and that makes you think even more, okay, were they both exposed to the same thing? Maybe in utero or in early childhood at a vulnerable period. More can identify relatives beyond first degree, so cousins, etc. The prevalence of MS will vary with geographic latitude. That probably has something to do both with the exposure to sunlight and vitamin D pathways, as well as with native infectious diseases and toxic exposures, but the range is somewhere between 40 per 100,000 and over 200. Canada has the 5th highest prevalence with an average of 133 per 100,000. But in some parts of the prairies, like Saskatchewan, the rates can go very, very high, even more than 240 per 100,000. Asian and African populations, they're the least affected, but it can affect persons of all background. I recently gave a talk at the American Congress of Rehab Medicine, and I was asked a question about this, and I basically have seen everyone from every ethnic background except Native/Indigenous Australian, but that doesn't mean that there aren't any reported cases. So really, it is a global phenomenon, and it affects all of humanity. The most common symptoms listed in decreasing frequency would be fatigue, balance problems, weakness across the forelimbs, problems with sensation, problems with controlling bladder, spasticity or muscle stiffness, and bowel issues. Memory impairment becomes increasingly common as the disease progresses, and there's a very high point prevalence of depression. So mood problems associated with MS is a really key feature of the disease that is sometimes under-recognized and under-treated. But treating it can make a very big difference on quality of life. As I alluded to in my previous breakout session, exercise is one way to address mood issues in MS, but not the only way. Then, of course, there's a whole host of pain. Pain in MS can be primary, so it can be related to the MS itself. There are phenomena like Lermit's phenomenon, when you get sort of those electric shock-like sensations going down your body when you flex your neck, all the way to pain from spasticity and secondary complications, pain from the affected nerves themselves. And then there are secondary pains. So, you know, being in a wheelchair all day, you can get sore in your back. You know, there's a whole host of different ways that MS can cause pain. Emotional lability or easily changeable emotions, visual disturbances, tremor, speech, word finding problems. So the point I'm trying to make is that MS, being a disease of the brain and spinal cord that controls pretty much the rest of the body, you can get symptoms across every body system. And so really, when you're approaching treatment, you really can't just think about the MS itself. You have to think about how it's affecting each and every body system. And you want to tweak each and every body system to be the best that you can be. There are 4 main types of disease courses in MS. There's the relapsing remitting, which is the most common. About 85% of persons diagnosed fit into that category upon diagnosis. Those persons tend to progress to a secondary progressive stage, and then there are persons with primary progressive, so they never really have discrete relapses. And then there are some cases where there are persons that are having a progressive course from the beginning, punctuated by relapses where they're worse. Rehabilitation efforts really can go across the disease spectrum in terms of severity and disability load, but also goes across the spectrum of disease course. This is the Expanded Disability Status Scale of Kurtzky. This is an abbreviated picture because it doesn't show the half points inherent to it. But why I'm showing you this is that for most of my patients, most people who are actually going to seek rehabilitation services, they reach an EDSS of about 4. And just to put it in perspective, when a person reaches 6.5, they need to walk with bilateral support. So they really have graduated to a walker, to 2 canes, 2 crutches, and by 7 they need to spend some time in a wheelchair. So that just gives you kind of a ballpark sense. This is how MS specialists, MS researchers talk to one another about who they're including into their research studies. It's very heavily weighted to mobility, so it's gotten some bad flack because of that. There are a lot of disease-modifying treatments out there for persons who are in the relapsing, remitting course of the disease. And now I believe that Canada has 10 approved therapies. They're typically discontinued once a person has evolved into the secondary progressive phase, and they're usually not offered to persons in primary progressive phase. The currently available options may or may not impact disability progression. There aren't many studies that actually look at disability progression when they're looking at outcomes or primary outcomes for how well the drugs work. So hopefully in the future we'll get more information about that. So you really need to, again, target your disease in a multi-pronged way so that perhaps you can actually affect the disability and not just the disease. We do know that high-dose steroids, whether you're taking them IV, whether you're taking them orally, they shorten the duration of relapses, but they really don't seem to modify the underlying disease. So where does that leave us? Does that leave us in the forest, completely in the dark, unable to get out? Where are we going to see the light? So hopefully you're going to see the light by empowering yourself with knowledge and being able to take that knowledge and translate it back into your own daily life and to make sure that you're getting the resources that you need to target your symptoms and maximize your function. Really, the overarching goals of rehabilitation are to reduce the severity of MS-related symptoms, to improve or maintain, in persons who are progressing at a quick rate, the very highest levels of function, not just for themselves as a person, but at home with their family and in the community. And that includes vocationally. I saw up on the rotating slides before my presentation that 80% of persons with MS at some point will become out of the workforce. And that's not necessarily by choice. So, you know, there are ways to target and being creative to try to see how we can improve those statistics. Helping with coping with the disease is very important, and institutions like the, or organizations like the MS Society, they're very, very important. And coping is so critical in making sure that the whole person is taken care of. And the whole goal eventually is to achieve the maximum quality of life, okay? So the focus of rehabilitation, and that would be all the rehab providers, but in particular going to see your physiatrist if you have one, is that the needs of the whole person be addressed. That would be psychological, physical, social, and spiritual. It's really a holistic model, okay? So it's not just about the demyelinated axons, it's not just about the cells in one part of the nervous system or another, it's about the person. And the person doesn't act in isolation. The person interacts with family members, interacts with partners, interacts with the community. And that interaction is incredibly important. And one of the unfortunate things that tends to happen to persons with MS as they go through the disability scale, as they go through the disease course and accumulate what we call burden of disease, is that there tends to be increasing social isolation. We know that that's not good for the brain. It's not good for the person. So we want to really be quite aggressive at reducing social isolation. The key concepts in rehab that I think are really important to note, and there's ever-changing terminology, are the concepts of impairment, abilities, and social participation. These are the newer terms that replace disability and handicap in respect to abilities and social participation. And really it's a focus on being positive. It's a focus on saying, okay, well, there are certain limitations. There may be limitations in mobility because of weakness. There may be limitations in cognition because of lesions in a particular area of the brain. But how does that translate to caring for oneself, caring for others, and then being a full member of the community? And there are interactions each way. So in terms of a rehabilitation approach, all three layers are addressed. The impairment layers, trying to make those symptoms the least impactful as they can be, trying to make the person as fit as that person can be, and then hopefully having a secondary effect on independence and participation, being able to go out and do the things that you want to do. In rehabilitation, sometimes we're not able to actually necessarily directly address the underlying disease. And I'm not speaking here in terms of MS in isolation. Rehabilitation as a specialty is looking at persons that have had high-level changes in their function. And that could be due to traumatic reasons, could be due to things like stroke, etc. And these are the concepts that we use to help people manage with severe limitations. And that would be to restore the function if possible, to compensate for the function if we can't restore it, to make sure the environment is adapted as much as possible, but that also the person adapts, and that could be psychologically adapting as well. And then managing the environment and reducing barriers. We're very fortunate to live in a society, I say that generally speaking, in Canada, that has really worked hard to reduce environmental barriers, so that persons who are at the wheelchair level, for example, have access to conference events, that have access to sporting events, have access to shopping venues, have access to theaters. This isn't the case in all places, and we still have to work to be as inclusive as possible. But that can have a huge impact on a person's well-being, just to be able to get out there and to do it. So this list that I have in front of you is not super inclusive. I don't mean to offend anybody who didn't make the list. As you can see, if I included more, they would be off of the slide. And no disrespect to the neurologists, they're certainly there on the team, but most rehabilitation facilities are separate from the acute care hospitals. That's in the vast majority of places. So rehabilitation facilities are typically separate buildings. They may or may not be affiliated with an acute care hospital or an acute care center. The physiatrist is the medical specialist on the team, and he or she works with a whole host of other professionals. And on the team, a physiotherapist is very crucial in terms of helping with mobility issues, weakness, strength, balance, training, walking, using wheeled mobility to the best effects possible. The occupational therapist is really important in making sure that the home is set up properly, that devices are appropriately prescribed. That includes wheelchairs in most centers. Training on energy conservation and pacing, trying to compensate for cognitive problems like memory issues. The OT is a really important member of the team. Then there's the speech language pathologist, a person who looks at speech and swallowing, a dietitian to look at making sure the person has all their core nutrients so that they can expend energy to the best of their abilities, recreational therapists to look at leisure pursuits and maybe adapting them to increasing mobility restrictions, etc. Persons to counsel on vocation. So, you know, if a certain impairment impacts how you can function in your office, well, how can that office setup be changed? Or is there another job that would be better suited to the level of impairment? community resource workers to put people in touch with the available resources around them, social workers. I mean, it goes on and on. Clinical nurse specialists, you've heard one excellent one this morning, neuropsychologists, spiritual counselors. So the team-based approach recognizes that a person is not just one thing. A person has many roles, many functions, and not everybody needs every member of the team. But I think it's very empowering to know that these persons exist, that there are professionals out there that can help in different domains. And I would challenge you all to try to find out for yourself if you have access to some of these therapists and professionals if you need them. I just want to make a plug for physiatry because I often get called a podiatrist or a psychiatrist or a physiotherapist, and it's a medical doctor specialized in physical medicine and rehabilitation. It's been a recognized specialty in Canada since 1947. It has two main arms, the musculoskeletal arm, which looks after impairments of muscles, joints, tendons, ligaments, etc., and neurorehabilitation. I already alluded to that. It goes beyond and above MS. My practice is exclusive to persons with MS. I focus on that entirely. So that's slightly atypical. There are many physiatrists out there that are much more general. And there are overlapping competencies with neurology, but again, the emphasis is on management of the effects of the disease. And it's the effects not just on the body, but the effects on the mind, and the effects on the family, and the effects on the person as a whole. So generally speaking, and again, I want to say generally speaking, because you can never say never in medicine, the physiatrist is not the person to make the diagnosis. That will typically be the neurologist. Generally speaking, the physiatrist is not the person to decide on the administration, selection, and monitoring of disease-modifying drugs. Again, that would be the neurologist. And finally, generally speaking, a physiatrist is not the person to order steroids during an acute relapse. Okay? The Canadian Association of PMR, so Physical Medicine Rehabilitation, says that there's currently about one physiatrist for a population of 110,000 people, but it's pretty much accepted that that number is too few. I alluded to this when I showed you the EDSS table, that typically a physiatrist becomes involved when a person reaches the 4 to 6 level mark and beyond. That's not to say that there's no role for the rehab team prior to that. And in fact, it's probably one more of resource allocation and resource management, and the fact that there are few physiatrists. So what am I interested in when a person comes to me and meets with me? I want to get to know them from the moment they got their diagnosis to the present, but even prior to getting that diagnosis. So I do want to know what the most pressing complaint is, and I do want to review all their symptoms that they have. I want to know how the diagnosis came to be. I want to know about relapses, when they last had one, if they had relapses to begin with, if they've had things called pseudo-relapses. So those would be attacks that aren't caused by new areas of inflammation. They would be exacerbations of the underlying areas of damage. And those exacerbations can come about because the body is trying to fight infection, the body is dealing with some other kind of stressor, and often they get kind of confused in a patient. The patient might think they're having a new attack when really, when it's teased out properly, they're having a pseudo-relapse. So treat the underlying problem and they bounce back and get better. I want to know about every non-MS medical related issue, and I want to know about past and present medications, habits, is a person a smoker, how much do they drink, etc. I want to know especially about medical use of marijuana or recreational use of marijuana. It's very controversial because there are some clear benefits of cannabis or cannabinoids in terms of spasticity and neuropathic pain management, but there are also risks. So we talk about balancing those risks and trying to come up with a happy medium. Family history is important. Social circumstances, the home environment, including Environmental barriers. Is a person with increasing falls, increasing mobility impairment living in a 3-story home without the ability to get from one floor to another very easily? Those are the kinds of things I'm querying. And I want to know how they're functioning on a day-to-day basis. Can they look after themselves in all facets? And can they actually leave their house and go about doing their business? Can they do their shopping? Can they go to the bank? Have they been doing well at work, in their work environment? Sometimes a person who's going through MS and is reaching a stage of increasing impairment burden comes to realize that their current environment looks like this. Very challenging. Just really everything at cross purposes and uphill. But there are ways to flatten things out and make things easy. But it takes being creative, it takes help, and it does take resources. Sometimes outside organizations can help with that. And in my practice, I do rely on the MS Society to help out in certain instances. You know, taking a holistic approach for the person means that I do have to delve into the background of the person and the relationships and especially family life. Are there challenges happening around them in their other family members who are maybe recruited to care for them? I want to know about how socially isolated a person is. And again, all of the activities of daily living. So feeding, toileting, bathing, grooming, dressing, transferring, walking, wheeling. So an initial visit with me is a lengthy prospect because we have to go over so much. But then it becomes easier all along. And really, it's about forming a relationship where, again, you're known as a whole person, and it's not just one target that we're trying to do. But again, that's the purpose of the rehabilitation. Other encounters have a different purpose. These are just a selection of gait aids that I might prescribe to patients. And I prescribe a lot of braces. And some of the questions that I get around prescribing braces is this going to make me worse? Well, that's a tricky question because some braces will definitely challenge the body to fight off deconditioning or being unfit. And other braces may exacerbate that. So I'm going to clarify. Any brace that it would be prescribed to the leg is going to enhance an ability to walk. So it's not going to take away an ability. It's going to enhance an ability. So you never have to worry in terms of a brace on a leg or even a brace on an arm that it's going to make things worse. The only kinds of braces that you really have to be concerned about in terms of becoming quote-unquote dependent on them would be braces to the trunk. Braces to the trunk, so corsets, things called thoracolumbo-sacral orthoses. There are pros and cons to using them, and they have to be used appropriately. Things like abdominal binders that are devices that go tightly around the abdomen and try to push the diaphragm up to compensate for weak abdominal muscles and to try to help the person breathe a little bit more easily. They, for example, should only be used up to 4 hours a day and in a particular posture. And that's because you want to make sure that the person isn't further weakening their abdominal muscles. But in terms of a brace for the leg, and I'm going to say this over and over again, you cannot become dependent on it, and it really will enhance function. Because in order to use those braces, you need to be up and you need to be about. So I wouldn't be afraid of that. I would encourage you, if it's recommended to you, to pursue it, at least to try it. I'm going to run through a survey of typical MS symptoms and the rehab approach to them. Please do stop me if there's a term that I'm saying that is out of line or too jargony, or stop me if clarification is needed. A person in my practice often complains of pain or problems with sensation. So pins and needles sensation, lack of sensation, difficulty knowing where their joints are in space. So we look to make sure that sleep is well restored, that any depression or anxiety is aggressively treated, we look to exercise. And exercise is going to be a theme that you see recurring in many of these slides, because more and more we're understanding that exercise is not harmful for persons with MS. To the contrary, it may actually be the key to stalling the progression of the underlying disease, but not only that, treating by various different mechanisms each one of these symptom profiles that I'm mentioning. We know that exercise, especially aerobic exercise, is critical in the management of chronic and especially neuropathic pain. There are a whole host of medications that can target nerve pain, and we won't go into each one of these in detail, but just that there are a lot. So pain is something that really, if possible, you should try to advocate for yourself to get it to the best, lowest level that you can tolerate. The key to pain management is not so much eliminating the pain, because sometimes that's impossible to do, but to get it to a point where you can maximize your function. Obviously, there are a whole host of other aches and pains, especially of muscles and joints, etc., that can come about by not using your body in the way that it was originally intended to be used. We were evolutionarily designed to be up and to be moving and to be walking most of the day. We were not designed to be sedentary. So the more sedentary we are, the more we do feel that stiffness in the shoulders and the tightness at the back of our neck, and I can go on and list things. All of those secondary problems, they also need to be treated. And they need to be treated so that they don't exacerbate the underlying nerve pain, and that, again, they don't interfere with function. So I hope you're taking from what I'm saying how important the concept of function is. And each one of you, I know, wants to be the best that he or she can be, and wants to be as independent as possible. So managing the symptoms, focusing on the exercise, and taking charge of your own health care if you can advocate for yourself or for your family members, that is the best way to ensure maximizing the function and mitigating the rate of decline in what ends up being a chronic illness. Mobility is key. Most of the patients that come to see me, even those who have been in wheelchairs for years, they come to me with their chief complaint of, I want to walk, or I want to improve how I walk. Sometimes it's easier to make those improvements than at other times. But physiotherapy input, a graduated home exercise program, avoiding overheating, avoiding exhaustion, paying attention to the possibility of bracing options, using gait aids wherever possible, using wheeled devices, changing the environment, using adaptive aids to, manage a weak grip or reach, further than a person can safely do so. Those are really important concepts. There is a medication out there that sometimes can be helpful for walking speed, and it has actually been approved in Canada over the past couple of years, and it's marketed under the brand name Vampira. But I've been prescribing for aminopyridine, which is the sort of generic short-acting form for many, many years, and off-label to try to see even if I can improve strength in the upper limbs. Spasticity. So this velocity-dependent increase in tonic stretch reflexes, fancy terms for real stiffness with movement across a joint. It responds to eliminating all types of noxious stimuli. And the most important thing to eliminate would be a signal from the bladder. A distended bladder is one of the strongest signals to winding up tone. Tone is another way of talking about the muscle stiffness. And I can't impress upon you enough how important it is to try to achieve meticulous bladder control. With the help of your physiatrist, your neurologist, or your neurourologist, it's very important to get bladder symptoms under control because they really drive, in many instances, spasticity. Bowel can be a very noxious trigger if a person is constipated, and when you stop being as mobile as possible, that's where problems with constipation start to come in. Of course, I'm making things sound too easy. There are a whole host of factors that need to be looked at when dealing with issues of bowel or with bladder, but the important thing is not to forget about them when you're trying to manage your spasticity. Positioning is very key. So positioning in a chair, positioning in a wheeled device, positioning in bed, these are all very important because certain positions will inherently increase tone and others will dampen it down. Exercise, aerobic exercise such as cycling, cycling with the arms, cycling with the legs, and sustained stretching are really, really important. So knowledge transfer on how you can manage these impairments on your own or with the help of your family members or therapists is very important because it's not just all about giving a medication. There's more to it. Having said that, there are a number of antispasticity agents on the market that can be used solo or in combination to, again, improve the ability of that limb to move through space. The thing with spasticity is that it's not always a negative thing. So it's really an individualized treatment. Is the spasticity a problem or is it helping? Sometimes people use spasticity in the legs to actually be able to stand and to perform some of their activities of daily living in a standing position when they would otherwise be too weak. So you don't want to take out that spasticity if you can help it. So there's really a balancing act and you want to make sure that you're being addressed by an expert. There are injectables directly to the muscle. There are surgical procedures that can happen. So there is a whole slew of ways to address this problem. And I'm just trying to give you kind of a sense of all the different I's that need to be dotted and T's that need to be crossed when you're going through your symptom checklist. Fatigue, so important. This is a universal, almost a universal complaint in my practice. Very important to look for competing problems and to treat reversible causes. Sometimes the thyroid gland is not working. Sometimes persons are anemic. Many of my patients have sleep apnea. And sleep apnea, so stopping the oxygenation to the brain during sleep, can be caused by a central problem, so a lesion that would control breathing during sleep, or weakness in the oropharyngeal muscles that relax quite a bit during sleep and then obstruct the airway. And both of those are seen more in persons with MS than in the general population. So I send people for a lot of sleep studies. There's really interesting research coming out of McGill and Daria Trojan's group on this particular topic. Needless to say, things that affect the general public also affect persons with MS. Do not necessarily accept that your symptom is an MS-related symptom. If you have an inkling that it's not MS-related, make sure that it's worked up and competing diagnoses are eliminated. And that goes for age-appropriate cancer screening, and that goes for age-appropriate screening for other problems, such as hypertension and diabetes. You want to make sure that you're pacing yourself, that you're doing things in short bouts, and that you're resting when you can. You want to do things that are with energy conservation in mind, and avoiding things that are too energy costly, or making a decision on priorities. Well, I want to do something, I know it's going to make me super tired, but it's going to really make me happy to do it. So just prioritizing and knowing what to expect on the other hand. Sleep, I can't say how important sleep restoration is. So many of my patients are not sleeping because of spasticity, because of pain, or because they're getting up to go to the bathroom. Those things can be targeted. There is a way to address each one of those problems. Now, you might not get it right on the first try, but there are second tries, there are third tries. And so I encourage you, make sure you're getting a good night's sleep. Try as you might to do that because it's going to have an important impact on your daytime energy levels. It's also going to have an impact on your mood. It's going to have an impact on your pain. It's going to have an impact on your tone. So it's all important. Again, temperature management. Don't be overly warm. I explained the mechanism behind that in my breakout session. Needless to say, if you want your neuronal pathways to work to their best potential, even through areas of partial demyelination, you need to stay in a cool environment. It just works that way. Exercise, again, It's not going to cause fatigue just while you're doing it, but it's going to mitigate the fatigue the rest of the day if you're doing it properly. There are a host of medications that can boost your energy, and they can often be quite effective, some more than others, and it depends from individual to individual who will benefit more from one or the other, but they're worth trying, so you should know about them. So make sure you explore all the avenues. You don't have to accept a particular treatment, but you should know that it exists, and you should be able to make an informed decision. You should be able to take control for yourself of how you want your care to be given. Again, for aminopyridine or 4-AP, I sometimes use that, I say off-label, to boost energy, and I'm hoping that it will become in the future an on-label use of Vampira. This is a very busy slide, but I kept it busy on purpose because I don't want to I don't want you to underestimate the impact the bladder has on quality of life, on your daytime functional ability, your ability to go out and participate in the community and to stay employed. I have a number of patients that have actually thought about quitting their jobs because of their bladder dyscontrol. They just were not being successful at keeping the leaks at bay. And I want to say there are a number of strategies to keep those leaks at bay. And one of the things that you can do is you can be on a schedule for going to the bathroom. I want to say don't fluid restrict, although most of my patients have at one time or the other stopped drinking. Stopping drinking, sure, works in the short term, but it causes a whole host of other problems, including exacerbation of constipation. So, you know, you want to address things in the best way possible, and you want to look for the medium to long-term solution, not the short-term solution. So you do need an appropriate workup. If you are sitting in this room and have never had an ultrasound of your kidneys and bladder, personally, I think that's wrong. So I'm going to challenge you all to make sure that you've had that done. In my clinic, I'm screening every 2 years at a minimum. So that's to look at things like, can you empty completely, or are you retaining? And how much are you retaining? Because retaining a little bit of urine in that bladder can be manageable. Retaining a lot, and my cutoff is about 100 milliliters, that's too much, and there are repercussions for that. I won't go into those repercussions in detail now, just that you need to know that you should be screened by ultrasound. There are higher level investigations such as urodynamic studies where the bladder itself is filled with usually distilled water or even saline, and pressures are measured and recorded to see also when the bladder contracts spontaneously. And sometimes those lead to a more invasive assessment by cystoscopy. So a urologist will take a camera device and go in and look at the lining of the bladder. These are things that may be very important in terms of looking at your overall bladder health, remembering that problems in the bladder can have secondary repercussions to other systems in the body, especially with respect to spasticity. There are a whole host of medications to address bladder dysfunction. There are some medications that even can kind of shut down the kidneys for a time, just to give you a good night's sleep. You have to talk to your doctor to see if it's safe for you. But for persons that are constantly waking up, have tried everything else, and really just need once a week to get restorative sleep, I have prescribed that with good results. I talk a lot to my patients about clean intermittent catheterization. Sometimes I get sort of a startled look, oh my gosh, doctor, what are you trying to suggest for me? But really, it can be a very liberating experience for persons who can either do it themselves or have someone to come in and do it. Then there's a whole host of other options like condom catheters for men, indwelling catheters for both sexes. There are things like intra-bladder Botox injections, which can again help with the spasticity of the bladder, because the bladder is a muscle and it can also become very twitchy just like the limb muscles. So it can be dampened down. There are other surgical interventions, but they're rarely used, but they're there. So you should know about them. Bowel dysfunction, I touched upon this before. This can also have a huge impact on quality of life and just your feeling of comfort at home. High fluid, high fiber diets are very important, as is a predictable bowel program. And then there's a whole host of reflexes in the gut that can be maximized. We won't go into the specifics today, but if you're struggling with bowel control, make sure you ask your doctor about these reflexes and how to maximize them. Again, sometimes a person doesn't even know that they're constipated. Sometimes they're having overflow diarrhea. And they think, oh, doctor, I'm having loose stools. Why is this happening to me? Well, it actually could be constipation. So a simple thing like an x-ray of the abdomen can actually be very meaningful to check to see if you really could benefit from more aggressive laxatives and other measures to get rid of the constipation. One of the things that we talk about, and we try to talk about it with any person who wants to talk about it, is sexual dysfunction. This is very common for persons in the higher EDSS ranges. When you have bowel and bladder dyscontrol or difficulties, dollars to donuts, there can often be problems with sexual function. So there are a lot of ways around this. There are behavioral strategies. There are changes to the environment. There are a whole host of specialized equipment, but that's a separate talk unto itself. And there are some drugs that can be used to increase the opportunities. So it's not just the doctor that can address this, the occupational therapist and the physiotherapist as well as clinical nurse specialists, the urologist. So there are a number of professionals that can help with this respect. Do not be shy to ask about this. This is something that is part of being a whole person, and you should make sure that if it's a topic that's important to you, that it does get addressed. In a busy clinic, sometimes this topic can kind of fall by the wayside. Do not be afraid to stand up and ask about ways to improve. There are ways out there. And again, creativity and trying, those are the best approaches. Certainly, scheduling to avoid fatigue can sometimes be a very simple step that can make a huge difference. Speech and swallowing assessments are really important to make sure that you're not putting yourself at risk for aspiration. And there are a whole host of augmentative communication devices that can be helpful. There are ways to improve balance and tremor difficulties. Although these are sometimes the most difficult problems to treat, there are things worth trying, including drugs. And I do have some patients who have undergone some surgical options. We talked about sleep issues already. I'm not going to go through that again. We talked about mood. I just want to highlight the importance of mindfulness and cognitive behavioral strategies. Mindfulness can be very important in terms of stress reduction and being present here in the now, and it's being shown increasingly to improve quality of life, mood across many different health problems. Sometimes it's even being advocated and used in schools for children. It really is not that hard to learn, and there are a lot of online resources and resources you can get even at your public library. I encourage you to look into mindfulness more. In terms of cognitive behavioral therapies, it's wonderful if you have access to a team, if you have a practitioner that knows how to run groups and courses for this. But there is a textbook that you can get through Chapters in Indigo or Amazon. You can buy it online. It's called Mind Over Mood, and it's a workbook that you can use yourself, and it is very highly effective. Diarizing, using agendas, limiting sensory overload, doing online brain training exercises, exercising your body. These are all things that can be very important to maximizing your memory and maximizing how you think. And more evidence is coming out about how important these things are. So again, even the most difficult to treat problems, there are some solutions by either targeting the problem directly or coming from around the problem and trying to accommodate, adapt, compensate. I want to highlight that a person with MS is at risk for other diseases and disorders that are common to the general public. So again, make sure that what you're suffering from is not simply dismissed as your MS. Indeed, it may end up being your MS, but make sure that a proper workup and investigation has gone on. Really take charge of yourself, advocate for yourself, or if you're having difficulty advocating, ask a trusted member of your family or a friend to help do that for you. General medical assessment is really important, age-appropriate cancer screening, as I mentioned previously. Just be aware that there are conditions that are more common in persons with MS, and I know my time is running short. I am very happy to stay late to answer questions one-on-one afterwards, but I do want to take the time to go over osteoporosis. Osteoporosis is very common in MS for a number of different reasons. It's complex. Some people would call it multifactorial. Certainly, immobility plays a role. Vitamin D, metabolism, and alterations in that metabolism play a role. Exposure to steroids over the course of the disease plays a role, etc., etc. It's important that screening be done for bone density, and in the general public, for women, it would come around menopause. That may not be the appropriate time for a person with MS of either sex. So if you've been having a lot of falls, or if you have been at the wheelchair level for many years, it is definitely worthwhile getting screened. So talk to your practitioner about it. Certainly you should be optimizing your intake of calcium and vitamin D. There are medications to control the rate of bone density loss and even to improve bone density. And exercise, certainly weight-bearing exercise, is critical in maintaining bone mass. So if you're struggling with walking, but you're able to stand, standing alone can be a very important therapy during the day. And again, making sure the environment is safe as possible to mitigate falls is really key, because you do not want to take a fall and suddenly have a part of your body or all of you immobilized for any particular length of time. You're really going to get unfit, and it's very hard to bounce back from that. So I'm not sure if we have time to go through the case. I wasn't sure at the end if we would, and that's why at the very beginning I said if we had time, we would do it. You know, I'm happy for anyone to have these slides. I'm not going to go through the case in detail, but if you do get my handout, you can read through it. It's a very typical example of a patient who comes to see me, and it goes through all of the ways that the symptoms are managed and that the level of functional independence is addressed. So, you know, it can be sort of a guide to, oh, I can see a little bit of myself in this person, and to make sure that you're getting your needs met. Okay, just have to fast forward here. Okay, so in conclusion, I'm hoping that you'll know that physiatry is a specialty, a recognized medical specialty that addresses impairments, abilities, and social participation through non-pharmacologic, so non-drug, as well as drug-related strategies. That exercise is a key strategy and is increasingly understood to improve a wide variety of MS-related symptoms and functional limitations. My breakout session was on exercise, and again, that talk will be available to you through handout, and I'm not sure if it's archived at all on the web, but at any rate, no matter what the stage and level of disability or EDSS score of a person with MS, that person can benefit from the expertise of the physiatrist and the team of dedicated professionals with whom he or she works. I am really privileged to be able to spend this time and talk to you today. As I said before, I'm very happy to take questions, and I hope you've at least taken home one or two pearls that can help you advocate for yourself and take control of your MS. Thank you. Any questions? Yes, ma'am. And that is why I'm speaking to it today, because it is under-recognized. And part of the reason it's under-recognized is that there are not too many of us, and even when we exist, some of us don't focus wholeheartedly on MS. But I am on a mission to change that. I really am. And I'm hoping to clone myself. I'm hoping to train others to do what I do and to start a real fellowship program in MS rehabilitation so that this holistic approach can be tailored to meet the needs of MS patients, not just at my center, but beyond my center. So, I mean, it has been around. It's been around in the US. It's been around in Europe for even longer. So I'm glad that you now are aware of it and that you can ask your neurologist about the opportunities in your local area to get a physiatrist involved. I think that's it, and I think I'm going to rest my voice now. Thank you again.
I'd like to thank Dr. Bruno for presenting such valuable information on this very important topic. On behalf of the Manitoba Division of the MS Society, I wish to express our gratitude to the sponsors. Without them, this conference would not have been possible. I'd like to thank Biogen IDEC Canada Inc., Teva Canada Innovation, Novartis Canada, and the Winnipeg Free Press. We would also like to thank Pharmacy at Safeway, Genzyme Canada, and the Specialty Health Network of Shoppers Drug Mart. And one more note of appreciation goes to our dessert sponsor, the South Beach Casino and Resort. I extend sincere appreciation to our speakers that made MS Connect 2014 such a fascinating and memorable day, Pat Kennedy and Dr. Tania Bruno. Our breakout presenters, Pat Kennedy, Amy Yonda, Kathleen Hornshaw, Dr. Michael Kasoy, Dr. Tania Bruno, Laurel Dick, Joanne Findley, and that's it. A special thank you to our peanut gallery participants as outlined in the program. It's always nice to welcome Charlie and the gang. Melissa Nance of the MS Clinic, Branka Jelsek of the MS Clinic, Linda Johnson, Driver Assessment and Management Program, Natalie Pearson and Glenys Beardy of the Independent Living Resource Center, Wanda Johannesson of the Safeway Pharmacy Operations, Audra Colasar, Dialetician Provincial Health Contact Center, Vicki Rosenholt of Victoria Lifeline, Willeen, Bob, and Paul from the Northland Home Healthcare, Stacy McCruer, Communication Device Program, Deer Lodge Center, Yada Frick, Disabilities Issues Office, and Ria Vags Olofsson, Wellness Institute at Seven Oaks General Hospital. And finally, and lastly, I'd like to thank our planning committee, Ellen Carr, Deanna Austin, Melissa Nance, and me. Before you leave, if you could please complete your evaluation and submit it to the registration desk just outside the front door, that'd be much appreciated. And don't forget to enter your email address on your evaluation form or at the registration desk. This way you can keep up to date on programs, research updates, activities, events, and much more. As our conference draws to a close, I'd like to thank our esteemed speakers for broadening our perspectives, inspiring us, and empowering us to live our best life. Thank you for attending MS Connect 2014.